evening. Welcome back to another episode of Let's Talk About Mental Health. I'm Nels Kloster, an addiction psychiatrist who works in Southern Vermont.
And my name is Robert Stack. I'm a licensed mental health counselor, licensed alcohol and drug counselor. And good evening.
Yeah.
One of the things that's been really sort of strange is that lately, this show has now almost become current events.
Right.
We open a paper or look at a headline, they're talking about heroin, they're talking about all the various bills that were before the assembly, state legislature. It's just, I was reading an editorial page, they were talking about the heroin problem, and they were talking about Afghanistan and Iran. There was articles in the paper about heroin and the focus. I understand Governor Shulman's giving a talk tomorrow. There's a panel up at Northfield Academy, I guess it is. They're going to talk about addiction. It just seems like there's an awful lot of news about addiction and mental illness. So one of our first questions that we want to answer, we want to thank everybody who's been sending in the questions by email and text. But maybe we could do the first question.
Sure. And then just a reminder too that the questions can come through us through email or through Facebook, and our site is facebook.com. Let's talk VT, and it is case sensitive. So the first question is: I've heard there's some controversy over a new pain medication. What can you tell me about this? Well, I could rant about this, right? I mean, there's this, the medication, the name of it is Zohydro, and it's basically hydrocodone, which is supposedly a bit of a weaker opioid than, say, oxycodone was. But it is a time-released formulation, and which means that you could take the medication less frequently during the day and get even release of the medication over the course of the day. So the idea is that less of sort of the peaks and valleys of using shorter-acting medications and have more even delivery of it and so more consistent control of your pain. The problem is that, again, as we found out with OxyContin, which is another time-released medication, is that for addiction purposes, for misuse, it was easy to crush and then snort, so that it was intended to be a day-long release of an opioid, was actually being gotten sort of one big rush. So that causes great problems, because then you're misusing it, and it became the favorite opioid on the streets. I mean, OxyContin was the main choice. Mm-hmm. So Purdue Pharmaceuticals made OxyContin, then was sued, paid a big settlement, and was forced to develop a tamper-proof formula. So what happened was that it was a gelling formula. So when people tried to crush it or to liquefy it for injecting, it turned into a jelly. So they were starting to call it gummies on the street. So people stopped using. So addicts stopped prescriptions from their primary care doctors, that stopped being the favored diverted opioid on the streets, and then they went to other substances. And there's been an assumption with this that the upsurge in heroin has been an aftermath of this, because as folks could no longer get this highly potent medication because there's so much packed into the one pill, that this left an opening in the marketplace for the heroin to be brought up from Mexico. So now this medication, Zohydro, is exactly the same thing all over again. It is a large amount of hydrocodone that's packed into this pill, and there's no tamper-proof protection in place whatsoever. So anybody who's in the know about addiction is looking and saying, wow, this is going to be the next abused opioid on the streets. And the particularly troubling thing about this is that the FDA had an advisory panel, and they said, no, you should not approve this drug because it does not have tamper-proofing in it. It's not, going to be prohibitive to try to misuse this. And despite this advisory committee telling the FDA not to approve this, they approved it anyway. And just sort of bringing comments from Harry Chen, who's the Commissioner for Health for Vermont, that they must be on a different planet from the rest of us.
Right.
Yeah. And
Yeah.
so from now Massachusetts just put out an emergency rule last week that's actually prohibiting the prescribing of this by doctors in Massachusetts, and it's prohibiting pharmacies from filling prescriptions. So if patients come in from other states with it, they won't be able to fill the prescription in Massachusetts. And Vermont has followed suit with a different approach. Rather than banning it outright, they have put some restrictions or requirements in place for physicians who might prescribe this. I mean, having seen those, one is that you have to document that there was no other choice for a pain medication. You have to do a thorough evaluation. You have to warn the patient about the addictive potential of Zohydro, and they're putting a limit sort of how many milligrams you can prescribe. But I think any of us that have experience with working with addiction will recognize these are really, really weak protections. And that Vermont is not doing enough to stop this thing from hitting the streets. If that's all they're going to do about it, I think an approach like Massachusetts would be a much better idea, just outright banning this thing. Because let's face it, people are going to die from this. Right. They're going to get a hold of this, and they're going to crush it, and they're going to snort it. They're going to do all, inject it, and with that sudden surge of that high amount of hydrocodone, it's going to be bad news.
After reading. Was it Robert Whitaker?
Right. Yeah, Anatomy of an Epidemic.
Yeah.
We had on the show a couple
weeks ago.
We had
him on a show, and a lot of the book was about the role of pharmaceutical companies and their faulty research. And I've been following this in the news now for the last couple of years about some of the research not being exactly what it should be, negative research not being publicized. And I used to be a pretty good advocate of taking medication. I used to be a pretty strong believer in people taking their meds and stabilizing their mental status so it could help enhance their recovery from addiction. But I'm really getting to a point now where I'm sort of losing faith. And I got to a point where I don't trust all research now. If somebody just says this is research based, it's like magic words now. It's just research, best practices. But I'm starting to lose faith in research because I'm not so sure. I find out about doctors who go on the panels who then go out and get money to speak, and there's all those problems, and they've cleared some of it up, but not all of it. And now one of the things that's become really clear is that, and I don't know, I mentioned this I think a couple of weeks ago. I still presume that pharmaceutical companies were acting in our best interest, but when something like this comes along, and you realize that they knew that OxyContin manufacturers made an awful lot of money making this pill. And I just don't see it. And I think you were sharing with me earlier, there was a column in the paper, somebody saying, a pain clinic, saying, we don't really need this drug.
Right, so at least some of the Vermont hospitals have come on right away saying, we're not going to use this. I think there's a pain specialist at Dartmouth or it was Rutland maybe, and a couple of doctors and hospitals, Central Vermont Hospital, and one of them said, this will not be on our formulary. I mean, the formulary is sort of the list of medications that a hospital keeps on stock and prescribes or permits to be prescribed. Right. And so already people are coming out saying, just forget about it. We are not going to even entertain the idea of using this medication.
Well, and I think it's going to backfire on the pharmaceutical companies. I mean, I think they may be penny wise, pound foolish. I mean, I think they, if they want to make their money, they can make their money. But there'll come a point in time. One of the sad things was when they were trying to adjust the health care, they decided that they would not force the government to renegotiate how much they pay for meds. That was one of the agreements that Obama made with insurance companies way in the beginning. And most people were sympathetic to pharmaceutical companies. They pay for research, development, all that. But I think they're going to lose it. They're going to lose that respect. They're going to lose their good name. Mm-hmm. And people are going to start saying, look, we're not going to do this. We're not going to go along. We're not going to, you develop a medicine for people and you don't charge us what it's cost to make. You charge us what we're forced to pay for it. You know what I mean? Anyway, so, I think this is just another example of here's a drug that's being produced, it's going to be made, and they're hoping to make a lot of money on it.
Yeah.
And that's all. And they could say they're doing it to help people with pain,
Yeah.
but I think we have an awful lot of medication out there right now for,
Right.
for
We don't
pain.
need anything else. Right. I mean, so we know that they spend a lot of the pharmaceutical companies spend a lot of money on their marketing budget, so that's suspect. And you know, whether you agree with the work of folks like Robert Whitaker, David Healy, that they are really concerned about the bottom line, making profits. That's their main purpose. You can't doubt that with this drug. With this being introduced to the market, even the fact that they would even consider creating something like this, I think is just kind of throwing it in our face that profits are what matter, and that our health is not a concern in the pharmaceutical industry.
Yeah, and if I thought about this article that was in the Rolling Stone magazine, and it's mostly about Vermont and heroin addiction, and they were talking about heroin, and not just in Vermont, but that's what they focused on. And they actually had two of the people they interviewed, both of them said they had started off on OxyContin.
Right.
And then moved on to doing heroin. Just the very thing that you said. Now, I know that's anecdotal and it's just, a couple of people, but I think that's a fairly clear pattern.
Yeah, we have to stop being stupid about this.
Yeah, there was no mass of people coming up here selling heroin to people who, it just didn't work that way. What happened was we had a lot of pain medication come up here, and that sort of went from there, and now it's gone to heroin. And now we look at this problem we're having. Yeah. So, okay. Thank you for
the rant there. I couldn't help myself.
That's all right. I'm glad you did. I mean, no, it's like, again, it's right in the news. I mean, people talking about it. So.
Yeah. So then the second question is, detox from heroin and opiates different than detox from alcohol? And how is recovery from opiates different from recovery from alcohol? Okay.
Well, I mean, I won't try and explain the whole detox difference between alcohol is pretty straightforward. I mean, I don't mean to belittle it, but I've done it been involved with people detoxing for alcohol for 30 years or so, but 20-something years, and it's usually over about the fourth or fifth day if there's no medical complications or anything. I mean, it's you got to be really careful about seizures, and if someone's been drinking, there's some risk. And usually, where I worked in the hospital, they used Librium to detox people. And that seemed to be fairly successful. Pretty straightforward symptoms. And people would get better. And I don't know, perhaps you could speak to, you could talk more about the difference. One difference I'll just remark on before we get into the physical difference. Alcoholics, I think, are sort of used to pain. I mean, they're always, they wake up sick every day. I mean, I don't know. I mean, they would really be suffering, and they'd be shuffling, and and some of them would want the Librium, and some of them wouldn't want the Librium. They would clean up pretty good in 3 or 4 days, and most of them were fairly polite about it. If they were in a blackout or something, or they would apologize for the way they acted or something. But the one thing I noticed in the hospital was that people who were detoxing from opiates seemed to be in some form of more emotional pain. I don't know about physical pain, though they tell me it's horrible, it's the flu and everything. But it really seemed to affect them on a level of, I hate to say grumpiness, but it was like, they were sort of like, this is terrible, this is horrible. And I've seen drunks suffer who literally apologize for sweating so much. I mean, it just seems like there's a different experience almost. And I'm not sure what that's about, but that's probably one of the things. And not being in nursing, I never had to medicate them or anything, so I could just observe them as counselor. But there was a real difference in their sense of responsibility, that they were sick, and an alcoholic really had a different sense than an opiate addict. And I don't know what that's about, but I just noticed that.
Yeah, and I think maybe to talk about similarities too. I mean, everybody, when you're at the point of being dependent or addicted to either one of these substances, when you withdraw, there's a sort of fight or flight piece of the nervous system that kicks in, and that's why a lot of these symptoms occur. And they're very uncomfortable, either one of them. and you go through what's called acute phase of withdrawal. So like alcohol, 2 to 4 days is when the major risks for say seizures and delirium tremens occur. And then opiates, depending on your level of use, 4 days, 10 days at the outset. The comparison is often made that you could have a seizure and die from withdrawal from alcohol. From opiates, you might wish you would die, but it's essentially like flu-like symptoms, and it can maybe levels of magnitude greater than we might experience with the flu. But that with opiate withdrawal, people don't die from that. What often say kills people associated with withdrawal from opiates is when their tolerance has been decreased and they go out and use, or they're so uncomfortable they say maybe inject too much heroin and then die from the overdose. So not the withdrawal itself that actually is deadly. Two, there's and it goes by many different names, but post-acute withdrawal syndrome is what I've heard most often. And the idea is that even though when that acute phase is done, the 2 to 4 days with alcohol, the 4 to 10 days with opiates, is there's sort of still a simmering level of those same symptoms that you have with either one of those. And that can go on for weeks or months depending on what the medication is, how long lasting it was. And then that's why we often look at it as very important, 90 days, 6 months, staying in treatment, because there is that vulnerability to relapse in that frame. So detox by itself is absolutely useless treatment. So if all you do is go to the hospital and go through with treatment for your withdrawal, you're going to come out of there vulnerable, and nobody stays clean if all they've done for treatment is detox.
I think that was one of the dilemmas working in the hospital, is that we did try and mix in treatment with detoxification. One of the reasons I lost my job is they sort of said, we don't think you need to do that anymore. We'll limit how much counseling they get at that time because they're all in detox. But it's just really different. I don't know how to describe it. Sometimes when you're talking to somebody who's in detox, you can get their attention. They're a little bit more willing to listen to what needs to be happening and stuff. And the reason I'm saying this is that sometimes recovery is different for alcoholics, and sometimes recovery is a little bit different for opiate addicts. And some of that is quite frankly, at least my experience, nobody ever recommended to an alcoholic that they go on Librium after they get detox. But my last few years of working in the hospital, I was an advocate for Suboxone, and in some cases I was an advocate for methadone. And the thing that was really difficult for me was normally I'm an abstinence-based counselor, but the relapse rate was so high, and I was sort of convinced that their best shot at being normal was to go on some kind of medication, and their best shot of avoiding legal problems and other health problems. So that was a little bit different for me. I still recommended Narcotics Anonymous to opiate addicts. I'd recommend AA to opiate addicts if they have a history of alcohol. A lot of opiate addicts will have alcohol prior to getting into opiates, and so the AA in some ways would work for them. But I would recommend NA to people in 12-step programs, and again, really changing the culture, changing who you were with, what you were doing, people you went. But it just, I don't know. We could talk about this again some other time, but I really, in my mind, I really ended up with a real distinction between being a very strong advocate for 12-step programs and alcoholism. If somebody was an alcoholic. I would tell them, that was the advantage of working inpatient, is that a lot of them had tried it on their own. They had tried different methods. They switched from beer to whiskey or whiskey to beer or whatever. By the time I'm talking to you, all those other things haven't worked.
Yeah.
And so I felt most comfortable, recommending abstinence, and the most successful way to remain abstinence is 12-step AA. But for opiates, I don't know. I look back now, that I drink the Kool-Aid, that I sort of buy into it. I'm not sure, but I used to recommend that they use medication-assisted therapy for opiate addicts.
Yeah, and it does have a good track record too, but I think we're starting to question the idea of how long anybody was on any medication and what's in people's best interest when you think about the changes that happen in the brain by being on a medication that impacts the receptor systems there. But it was swayed a lot of people towards these, so medication-assisted therapies for opiate dependency is that people have died. And you like to kind of stop that. You'd made a comment that caught my interest too when we talked about, because we both worked in the hospital together, and the alcoholics and their withdrawal, and then opiate addicts and their withdrawal, and the sort of demeanor around that. And I don't think this is just our own personal impressions here, but there's a culture difference, I think, between alcoholics and opiate-dependent patients. And I wonder, quite often the alcoholics would have had, say, a better employment history. They'd have had a better, stronger relationships, potentially, and just seem to be sort of better, more accomplished in general, sort of starting from a healthier baseline. And a lot of the opiate-dependent patients seem to sort of struggle with school, maybe hadn't completed at this higher rate, more difficulties with employment as well. And dare I say, sort of their interactions with us as staff seem to be a little more, carry more conflict with it than we would necessarily see with the folks who are withdrawing from alcohol. And I wonder if that's not sort of part of the outlaw culture that is part of opiate dependency. I mean, alcohol, it's sanctioned. We see examples of people drinking responsibly. You see advertisements for it everywhere, and you don't have to break the law to get a hold of alcohol. Right. Whereas when you start with something at a younger age, when you're less fully developed, and it's against the law, you're on the run, you're hiding around with this. There's the illegality of using it, buying it, selling it. That I think this has a tremendous impact then on the sort of the culture or the way of sort of carrying yourself and how you interact with other people. And I wonder if that's sort of a big difference we've seen too. That these are, while we say a drug is a drug is a drug and addiction is addiction, I think when we work to treat alcoholics, we work to treat people, opiate dependent patients, that we have to be aware that in a way there are cultural differences here. We need to be savvy to those cultures.
It was also an age difference. I mean, a lot of the alcoholic patients I worked with were at least in their 30s, if not 40s and 50s. And most of the opiate addicts I worked with were in their 20s, sometimes in their 30s. But most of them, I'd say, were in their 20s. And so I think there was a little, and like you said, alcohol is legal, whereas opiates were, for the most part, illegal for most of the patients I worked with. And that really I think was a real difference too. I mean, it's, some of that started to change at the end. I mean, I started, like I said, I was starting to see people who were not fitting the traditional who's an opiate addict, who's a heroin addict. If you ever had an image of a heroin addict, it really started to, I remember this sign they used to say, who's an alcoholic, and they had 35 faces, and they were all mixes of races and men and women and kids, and they'd say, everybody could be an alcoholic. And I think that's also happened with opiates. You used to have an image of who's an opiate addict and where they lived or whatever, and what kind of, but now you see it everywhere, and it's a little bit more difficult to say what is a typical opiate addict, because I don't think there is a typical opiate addict anymore. That's really changed. And I didn't mean to imply that they're necessarily meaner people than alcoholics. I mean, alcoholics can be as mean as the next one, but they really did sort of just. There was a difference, if you will, in the withdrawal, and the question was about withdrawal. So
I
just want to say that. I mean, they're
absolutely. And we knew if the unit was a larger percentage of alcoholic patients, we generally had an easier day. If there was a greater percentage of opiate addicts, then we knew we had a harder day in front of us.
Yeah, so and there's lots of reasons for that. Just trying to arrange aftercare, just trying to get their needs met. Alcoholics are just, they were going back to work, they were going back to home, for the most part, most of the time, and whereas there was different needs and stuff. And so, the alcoholic would ask to use the phone to call somebody at home to say, I'm sorry, or to say, I'm here in the hospital. And an opiate addict would have to use the phone 6-7 times a day trying to find somebody to provide them with Suboxone, or to get a ride home, or take care of legal problems. And it's a really different type of situation.
A lot more tension, right.
So,
And then we have another question. In one of your earlier shows, Robert said something like, if your family member is addicted, you are sick also. Could you please elaborate on that?
Well, I used that years ago. We used to have patients come in with their families for alcohol, and we used to try and let people know that alcoholism was a family illness. And so, but at the moment of admission, it's very intense. The family is so focused on the alcoholic who's being admitted, and you try and get their attention and say, we believe this drinking has affected you and your family, and we think you should probably also get some help, or at least consider going to Al-Anon or talking with somebody about what's been going on in your family. Because a lot of times in a addicted or alcoholic family, it's kept a secret, and it isolates the family members. And there's also a certain amount of shame sometimes involved. And obviously there's the repercussions about, about love in the family. So in order to get the family members' attention, if you will, people would say, well, we want you to know it's a family illness and you're sick too. And I was never comfortable with that because it sounds like you're calling them names. But I think it was really mostly for the shock value, to let somebody realize that, yes, it's true, the primary person is perhaps the alcoholic or the addict. But at the same time, they live within a system, and their behavior and their addiction affects everybody in the family. Yeah. My good friend John Moran, we had him on the show, Representative Moran. He used to talk about the family being in a car accident, and everybody in the car accident was injured or hurt, but in different ways. The back seat from the front seat, from what side of the car, and I think that's I think that still works on some level. Everybody is different in a family. Everybody has a different effect dealing with the person struggling with addiction, and each person's relationship is sort of affected by the drug, and over time it has a negative impact on not only the relationship but on them. So calling somebody sick sounds terribly judgmental. There's no vital signs involved. You know what I mean? You're making a generalization.
No fever. Yeah.
But the idea was really, we want to get your attention. We want you to while we're taking care of your loved one, this might be a good time for you to sort of relax, but also maybe go get some help for yourself. Find someone to talk to. Pastoral counseling is a great idea, individual counseling. And again, we used to recommend Narcanon or Al-Anon to people. So.
And knowing you, I know that it was not your intention to say, it's your fault this guy's an alcoholic.
No.
Right? This family here is such a mess. But try, everybody in the family is impacted. You can't say that the rest of your family is going to go on in a healthy fashion and just let the alcoholic member of the family or the drug-addicted member of the family carry on with their addiction. Like, maybe using the sick reference too much, things like, colds, pneumonia, that kind of thing. It's contagious. The whole family is impacted.
MSNBC had a show on last night, 2 nights ago, I don't know what it was. But it was about drug addicts in Jersey jails. And I turned it on. I wanted to see what they were doing, if anything different or anything. And this one guard, he called it a mama's boy illness. And I thought, wow, is he making fun of them? And he's not making fun of them. What he found out was that a lot of them, their mothers were giving them rides to buy dope because they didn't want them to be sick, and they were trying to take care of them. And he said this was showing up over and over again. And that really struck me, and I know that's true. I knew mothers that used to drive their kids down to Greenfield to get methadone. I mean, it's so...
Yeah, what an awful choice to have to make.
Yeah, should I watch my son or daughter be terribly sick, or should I give them a ride so that they can go get the drug that they need not to be sick? And boy, if you don't think that affects you, you just don't understand what that's all about.
Yeah, so awful choices, and would hope that people could find the place to make better choices. And
if I didn't answer that question, ask again, please. This has been a really fast show.
Yeah,
thank you. Good night. That's my camera.
That would be my camera.
His, and this is our
camera. I've learned to work the camera. And when I notice at the corner of my eye, that's my face on the camera, then I try to kind of work the camera a little bit more. Like I'm an expert.